Okay, perfect. Thank you. You can hear me, can see the slides. Perfect. Thank you. So I think the topic given to me is quite interesting, but it's quite large, quite big. And what I'm going to do in the next 25 minutes, give you a bit of a snapshot and we can have a discussion on it. So metabolic liver disease in children, the definition of it is anything that's wrong with the metabolism. That's how broadly could be done. I'm just looking into disorders of inherited disorders of metabolism. I'm not going into other conditions which are classified as metabolic like cholestatic syndromes. Metabolic liver disease, if you were to group them, the presentation in children in the following syndromes, they could present like an infantile cholestasis, just a jaundice as a presentation. They can present as acute liver failure. They can present as ascites, neonatal ascites, not a bigger children, or they have a hepatosplenomegaly or both. And last would be that a child with mild abnormal liver function test has hyperammonemia or acidosis. So this is a syndromic classification of metabolic liver disease. Each of these entities in itself will have a further discussions on diagnosis management. So this is a spread, the rare diseases. So you can see here, the metabolic liver disease can present like a small child, frog-like position, hypotonic. If you do X-ray of the knees, you can find some patellar classification. So the diagnosis in this case may be easier, very rare disease, but you can call Zellweger syndrome. Here you have a child with inverted nipples and lipoatrophy, you can say carbohydrate glycosylation defect. This is a child who has a massive subcutaneous bruising, prolonged prothrombin time, otherwise looks reasonably well, is tyrosinemia. If you see cataracts and cherry red spots, then we know you're looking at lipid storage disorders. The children who present with metabolic liver disease as acute liver failure, I think these are the diagnostic protocol that you can follow. So fatty acid hydroxylation defect, they have a coagulopathy, as I showed you in the previous pictures, those bruising in the child. Zellweger, the age varies, the diagnostic tests. The problem with these diagnostics is you can suspect, but there is no shortcut. You have to do tests for every single condition. So every single condition has their own diagnostic test. So fatty acid oxidation defect, you need to do organic acids. Carbohydrate glycosylation defects, you need to do isomerism or studies, or you need to do genomic studies that will come later on too. So the point of this table is, which you can't, it's not easy to remember. You only see it when you have a patient. You can look at, what features are there. Is encephalopathy is a major feature? Is tubulopathy is a major feature? In this is the relatively easier one, like neonatal hemochromatosis or Wilson disease or bile acid synthesis defects, where what the phenotype is significant coagulopathy and jaundice. Or if you have a Wilson disease, there's a coagulopathy, there may be a excessive jaundice. Bile acid synthesis defect, you have a coagulopathy is predominant, jaundice is not significant, and encephalopathy may not be there. And these are the tests that are on the right-hand side. What I'm showing you is the kind of primer, how to approach a child with metabolic disorder. So it's a very basic, it's a medical school level. We don't remember these tables and these diagrams, but to start the discussion, and you can have this in your textbooks, in the review articles. So acidosis, a blood gas, is an extremely important part of any sick child. So if you have any sick child, whether liver disease or not, a blood gas gives you a very good starting point. A blood pH, acidosis and ketosis, are normal or alkalosis. If you have a child who's sick but is alkalotic, in the field of liver disease, urea cycle may be the commonest diagnosis. If you have acidosis and ketosis, then we're looking at organic acidemias, fatty acid oxidation defects, and there is no shortcut, but you have to do urinary organic acids, you have to do acyl carnitine profile in the blood. But a starting point of a blood pH and bicarb-based deficit gives you a very good starting point. Similarly, if you have lactic acidosis, now lactic acidosis may not be always liver disease. There are other neurological conditions that cause lactic acidosis, but this gives you an idea that if you are a patient, is you are fasted lactic acidosis or it is persisting lactic acidosis, or during or only occurs when the patient is fasted. Patient is encephalopathic or not, and then patient is actually with ketosis or not. So then it points down towards respiratory chain defects or mitochondrial disorders, where a persisting acidosis in a child usually is organic acidemia and mitochondrial disorders that we worry. So if you have a child with lactate who is not high lactate, not dehydrated, we always worry about mitochondrial disorders. So what are the future trends in the field of metabolic liver disease? I think the diagnosis, once you have, and what are the trends in the treatment sector? So currently, diagnosis is made by the following headings. You measure a missing protein. So something is missing on somebody, you say somebody is factor 7 deficient, you measure factor 7 that's low in the blood. So that is a missing protein is you're diagnosed. You measure accumulated toxins. So in tyrosinemia, you look at succinylacetone, that's elevated. That's a toxin. Okay. You measure enzyme levels. So glycogen storage disease for that matter, or lipid storage disorders, traditionally you measure their enzymes. Then sometimes it's a clinical syndrome, which everything looks like this disease. Test may come back later on. And then in the end, I think for inherited defects, mutational analysis is what is becoming now the important thing of the future. So other than the first 4 or 5 I told you you all know that. The mutational analysis is 2 types. Either you have known mutations and you go for that, targeted approach. So if you suspect Wilson disease, you say, I want mutations analysis for Wilson disease. Or you have a cholestasis, you say, I will need either a cholestasis panel. So increasingly, we developed panels for conditions. So this is a cholestasis panel. This is acute liver failure panel. This is a panel when you have an acute liver condition with kidney failure or a liver failure with neurological problems. So those panels are developed to reduce the time that it takes to turn around and become less expensive. But whole genome sequencing is becoming increasingly used now, depending on the turnaround time, how fast you can get a result on that. How do we manage these patients? I think dietary management is extremely important in pediatric metabolic disorders because a lot of disorders are driven by the dietary toxins. I will give an example of galactosemia. And galactosemia, if you do not take the galactose away, you cannot help the child, whatever you do. So in our practice, a child who comes with a cholestasis in the newborn period, we exclude galactose from their diet till we prove that child is not galactosemia. Okay. The drugs, there are specific drugs, for example, tyrosinemia. You can use a drug called nitazisone, bile acid synthesis defect. You can use a cholic acid or quinodeoxycholic acid. So there are no specific drugs that are being used. Tissues, we do a liver transplant for that matter, or a kidney transplant if it's a organic acidemias. So those are the tissue replacement when you replace the organ where the genetic defect is there. You can use cells. So cells in this context in the liver disease is hepatocytes. If it's a diabetes, you can talk about islets, but in this context, we are talking hepatocytes. We'll briefly touch that. Small molecules means small RNA inhibitors are also coming into practice, and genetic therapies or gene therapies are also becoming increasingly now available. So what are the management options? So there are non-transplant management options. These are non-transplant. I already mentioned dietary restrictions, galactosemia, fructosemia, enzyme inhibition, NTBC or bile acid synthesis defect, enzyme induction, for that matter, you treat Crigler-Najjar syndrome, replacement of deficient metabolites, cholic acid for that matter, and removal of the toxins. Example is Wilson disease by using chelative therapies like penicillamine or triamcinolone. Now, when it comes to transplant, then we have 2 options. So you have 2 types of metabolic disorder. Either they are cirrhotic, means they have a chronic fibrosis in the liver, or they are non-cirrhotic single enzyme metabolic defects, where we come to what other options we can offer them. So when do you need a combined liver kidney, liver islets, or liver pancreas, liver heart transplant? Usually these are multi-system disorders. For example, primary hyperoxaluria, we try to do a liver transplant proactively, then you avoid a kidney transplant. But if a patient has come to you with advanced renal failure on dialysis, then they need a liver and kidney transplant. Organic acidemias, particularly methylmalonic acidemia and propionic acidemias, they have a expression of the enzyme outside liver in significant proportions. So you may not get a good benefit from just a liver transplant. And depending on the organ dysfunction of the kidneys or the heart, you may end up either doing a kidney liver transplant or combined heart, kidney, and liver transplant. In cystic fibrosis, the trend is towards doing a liver and pancreas or liver and islet transplants. So question will come, what will be the ideal treatment for metabolic defects? Okay. What will be the best? So if the ideal treatment in a condition where you can manage by dietary management, why don't you do that? If that fails, then liver transplantation is the next best. But our aim should be to looking at something which is correcting the underlying defect, and that will be a gene therapy. Now, the problem with the future and current situation is gene therapy is not easily, readily, or widely available for most of the conditions. So if you have a liver-based defect, and that disease may one day will be treated by gene therapy, for example, like Crigler-Najjar, for that example, a syndrome. And then if you take the whole liver away, then that patient will not have a target organ left for gene therapy. So this is a difference when you're practicing as a pediatrician versus an adult physician. In pediatrics, our life expectancy for our patients is decades, not years. So we are not expecting a liver transplant child to live 5 years, 10 years, 20 years. We are expecting them to live 20, 50, 30, 70, 80 years. So we need to be futuristic, and that's where our practice does differ and should differ from our adult colleagues. This is just an experience, a snapshot of what percentage of patients we get. So for that example, out of 600 transplants for chronic liver disease, about 1/4 were metabolic, and in acute liver failure, under about 5 to 7% are acute liver failure. Now, indications for transplantation for metabolic liver disease will vary from region to region. Alpha-1 antitrypsin is the commonest in our part of the world or Western world because alpha-1 antitrypsin is the most common liver-based metabolic defect, which is not the case in India for that example. So your pie chart will be very different than what I'm showing you now. So for us, alpha-1 is the first, Wilson second, then Crigler-Najjar, and after that, they become rare and rare. Propionic acidemia, methylmalonic acidemia, and the list getting bigger and bigger. Now, the question is timing of transplantation. So when should you transplant? I think timing is sometimes determined by the presentation. So if you have an emergency presentation, like acute liver failure-like presentation, so emergency liver transplantation is an option, like Wilson disease, neonatal hemochromatosis, or urea cycle defect. How do we decide timing in this? For some conditions, we have developed disease-based risk scores. So like Wilson index, which we described twice, improvising it works very well to avoid transplantation, I would say, or indicate a definite transplant. In certain conditions where the patient is very well, but there is a risk of neurological injury. So for that example, Crigler-Najjar syndrome, where there is nothing structurally wrong with the liver, but there is a risk of kernicterus or metabolic encephalopathy because of unconjugated bilirubin, or hyperammonemia in urea cycle defects, where you may find that patient may lose the brain function, may survive, but they have a lifelong disability. For chronic conditions like alpha-1 antitrypsin deficiency, cholestatic syndrome, Wilson, decompensation of the cirrhosis, not responding to therapies. Avoiding other organ damage. So as I gave an example of primary hyperoxaluria, these patients will not die of liver failure or liver dysfunction. They die of kidney failure, but the abnormal metabolite is coming from the liver. Same is Crigler-Najjar syndrome, hypercholesterolemia, where you're avoiding a cardiac risk. Those patients are not dying of liver disease, but they will die of a cardiac problem. Similarly, if you develop a malignancy in a patient who may have a compensated liver function, tyrosinemia, progressive familial cholestatic syndrome, glycogen storage disease. And the issue in GSD becomes very difficult because they develop multiple adenomas. And then it's very difficult to say whether it's a benign or it's a malignant. So some of them end up in transplantation. Quality of life, patient is not going to die of liver disease or liver failure, but their day-to-day quality of life is quite bad. And what do I mean by that? If you have a child with cholestatic disorder, Their blood tests don't look very bad. They are not very decompensated, but they itch all the time. And the family is not very happy. The child is not happy. So everybody is unhappy in the house. So they say, well, we will take the risk of liver transplant and you go for a quality of life. Similarly, critical NHR, some of your patients may be well controlled on phototherapy, but 18 hours, 16 hours, 12 hours of phototherapy may not be that easy to deliver. So that becomes an indication for transplantation. Then what is prophylactic liver transplant? Prophylactic liver transplant means could you avoid a future uh, problem? And for example, Walcott-Rollinson syndrome, where you have a risk of recurrent acute liver failure, and then increasingly, we are describing more conditions where every episode could be life-threatening. So some families with a bad experience will go for liver transplantation. And these endoplasmic reticulum transport defects, which will cause you future injuries and hence liver transplantation maybe. This is primary hyperoxaluria example where doing a proactive liver transplantation could avoid a future liver transplantation. So far we think liver transplantation is very good option, but what is the downside of it? The downside of it would be it is not futuristic because I explained that you have the option of gene therapy or new drugs coming in future. If you remove the organ, then patient will not have that benefit. There's a lot of echo, I don't know from your side. So we have attempted auxiliary transplantation, and these cartoons show that if you have a mature tree in your garden that doesn't give you good fruits, whether you can transplant it branch from another tree and you have a tree that have two types of fruits. So in this case, if your patient has two livers, one producing the missing enzyme and other continuing to carry on the functions that he was doing it before. So auxiliary liver transplant, a lot of surgeons I noted in the crowd were there. It's not a new thing for them. They say we have done it already. So for those people who have not known this technique before, right or the left lobe of the donor native liver is replaced by a normal right or left lobe donor liver. But this cannot be carried out in the children or patients who have a cirrhotic liver metabolic disorders because cirrhotic metabolic liver left behind with the risk of malignancy and portal hypertension. So it has to be on the non-cirrhotic conditions which are listed on the right-hand side. This is an example of auxiliary liver transplantation we carried out for Crigler-Najjar syndrome. That gives you a very good benefit. Within 24 hours, you see the bilirubin becomes normal. This was an unfortunate child who developed complications, and this slide is important because the complications has to be spelled out to the family. This is an example of a long-term outcome. This patient is now, this picture is from 2007, so you can add 15 more years to it. And this patient has auxiliary transplant propionic acidemia. And what you see is this patient still have this two right and left is donor liver and recipient liver. So this is long-term outcome. Then we introduced hepatocyte transplantation in practice. And what we found is that it was good short-term. So we had a normal ammonia, no dietary restrictions, but it didn't last more than 18 months. So for a short term, it was good, but if the patient is getting immunosuppression, then they may opt for auxiliary liver transplant, keeping an option for a gene therapy in the future. So this is where the concept of liver cell transplantation we have attempted, and so have others. Can you grow the trees or can you grow the liver? So the idea is that, if you transplant liver cells into the liver with an underlying defect, you give a competitive advantage to the cells that you're transplanting, and those cells can divide and repopulate the liver. The people who do not know about the liver cell biology, the liver cells do not divide easily outside the human body, and they only divide if you give them a lot of growth factors, but then the risk of malignancy comes. So dividing liver cells or growing liver cells, making them divide, is not easy. So in animal models, if you look at all these animal models has been cured of their metabolic defects with cell transplantation, liver cell transplantation, but the story in humans is not that straightforward. So, sorry, I missed it. What happened here? There are slides were missing here, sorry. So this, I think we missed some slides there. I will come later to that. Coming to the whole genome sequencing, what happens is the cost of whole genome sequencing has dropped dramatically. I think in India it may be much faster growth than the Western world because I think technology in India is advancing faster than anywhere. So this gives an example, when it started from $10,000, now I think people are getting for $250 also. And the reason to do a whole exome sequencing, not whole genome sequencing, is because most of the diseases that we are looking for are mostly in the whole exome region rather than the whole genome. So this is an example, 1% of human genome harbors 85% of disease-causing mutation. It's available in the clinic. So who should get it? I think increasingly every single child with unknown diagnosis, metabolic suspect, gets this whole exome sequencing done. This is example of whole exome sequencing or whole genome sequencing. We are getting these conditions which we didn't know before. So these are examples of RNA defects, so transporter defects. So this we didn't know before, but increasingly now while we're doing these things, we are getting these results. They do take several months, but at least we get diagnosis. What I want to touch briefly on is gene therapy. I think gene therapy for us is, for liver people, it's extremely important. I will show you why liver is most important organ for gene therapy. So gene therapy we can deliver in two ways. One is called ex vivo gene therapy and other is called ex in vivo gene therapy. Ex vivo gene therapy means we take the cells of the person, modify the cells ex vivo and treat with whatever viral vectors we want to give and then reinfuse back after the cells are grown. And there are quite a few examples which are not in the liver field, but like CAR T cell may be a near example where blood cells are taken out, modified, and then given back. Increasing most interest is in vivo therapy because ex vivo therapy will require a lot of infrastructure. In vivo therapy, everything is made in one place and viral vector is introduced into the human, and I'll explain to you how. So ex vivo gene therapy means you get a cell's gene repair and the same technique that we developed to transplant liver cells will be the use for ex vivo gene therapy. But for in vivo gene therapy, I think liver is an ideal target tissue for gene therapy because it's very vascular. So there is a higher delivery of the gene vector. It is relatively easy to access intravenously. It can go, most of the people have tried intravenous route, and there is a possibility of hydrodynamic gene therapy or other vectors if you want to use. And liver is seen as a bit of a tolerant organ to vectors. Ex vivo gene therapy has its advantages, but you need, either you need to remove the cells. In this case, you may need to remove part of the patient's liver, partial hepatectomy, which has been done to modify cells and give it back. But I think in vivo gene therapy is increasingly being favored over ex vivo gene therapy. The types, what can we do? So you can do a gene editing. So means the missing editing, like you have a typewriter and you have a misspelling mistake, you go and correct it. These days with the word processing. So it's similar technology, gene editing with, if you have heard of the technique called CRISPR-Cas technology, which is going very fast at the moment. Then you can add a gene, which is increasingly commonly done for conditions like Wilson disease or urea cycle defects or Crigler-Najjar syndrome. And there are clinical trials now on Crigler-Najjar and Wilson disease and urea cycle defect already on. mRNA technology, we all learned from our COVID trials how important it was. And now with mRNA therapy, which has become easier to go, that field is moving very fast also. And abnormal gene like in alpha-1 antitrypsin, you can silence the gene, so that doesn't lead to accumulation of alpha-1 antitrypsin. How do we deliver these genes? I think we can do adenovirus, but the problem with adenovirus is very immunogenic. Although it has a very big gene, transgene, it can carry up to 37 kilobyte gene. Lentivirus, the disadvantage is that they are very effective, but they integrate. So once they integrate in your immune system or your genome, then it's very difficult to have a genotoxicity in the future. The most favored virus at the moment is adeno-associated virus. And although it's a small, carries small load of 4.7 kilobyte, but it is the most effective because it is also not, it doesn't integrate, it's an episomal, and then it's a lot of new viral gene therapies are coming, they are coming with this AAV2. What is the real scene is, if you can see lot of, if you see hemophilia has made it to the market, Crigler-Najjar is getting there, Wilson disease is getting there in the clinical trials with good outcome. So this is a pipeline, and I think we will see increasing number of gene therapy trials coming our way. So to conclude, ladies and gentlemen, diagnosis can be a challenge of metabolic disorder, but whole exome and whole genome sequencing with rapid turnover time are going to be a real game changer. Liver transplantation is an effective and a safe mode of treatment for several liver-based metabolic disorders, particularly cirrhotic. Auxiliary liver transplant, we should increase this technique, in particular in patients who are non-cirrhotic. So that gives them a future hope of cell therapy, gene therapy, or small molecules that are to be coming in our guidelines. Metabolic toxicities are on the rise, at least in the Western world. This is a cartoon of children getting drunk. And I would like to thank my lab, who people helped me with my presentations and the data, and particularly the hepatocyte transplant program, clinicians and my patients. Thank you very much.